So, welcome back to Inside Tract from ABGH, the Association of Black Gastroenterologists and Hepatologists. I'm Dr. Ugori Roku, co-founder of ABGH, clinical assistant professor at Mount Sinai Hospital, and an IBD expert at Summit Health in New York City. I'm really excited about today's conversation and even more excited about the experts I have joining me today. First off, we have Dr. Yana Lewis, Assistant Professor of Medicine and Director of the IBD program at Mount Sinai West and Mount Sinai's Morningside Hospitals. Dr. Lewis has truly been a tireless advocate for improving IBD care and patient access across the diverse communities she serves. Dr. Lewis, welcome to the program.
Thank you so much for having me.
And we are also joined by the Dr. Tolu Falaye, Associate Professor of Clinical Pediatrics at Digestive Health Institute, Children's Hospital Colorado, in Colorado Springs. Dr. Falaye brings deep expertise in caring for young people with IBD and supporting families through every stage of the journey. Dr. Falaye, welcome.
Thank you. Glad to be here.
And before we dive in, I want to acknowledge many of you who are watching, whether you're living with IBD yourself or your partner, you're a caregiver, walking this journey along someone you love. We see you, your experiences, your frustrations, your resilience. That's at the heart of what we do every day and on this program as well. And today we're going to shine a light on one of the biggest yet most overlooked factors that affect you and your loved one's IBD journey. And those are those real world barriers to care that you face every day. And we're going to talk about some of the insider tips and tricks to overcome them. So to start off, we're going to talk about access and advocacy. And so I'm going to start with a stat, my esteemed doctor colleagues. A recent Crohn's and colitis survey found that over 50% of IBD patients experience delays accessing or filling medications. About 1 in 3 wait multiple days for prior auths. About 3 in 10 were denied coverage of the scripts given by their doctors. And about 3 in 10 report over 2 hours waiting on the phone to resolve prescription issues. I'll start with you, Dr. Lewis. Are you seeing this? And does this really matter in terms of patient outcomes?
Right. No, absolutely. I mean, I think the insurance aspect of things is really something that weighs on a lot of patients. I'm actually currently doing a study that's meant to look at mental health for patients with inflammatory bowel disease. And one of the factors that we found is the largest is the stress associated with insurance. And so we see it frequently, and it can be a huge hurdle. One of the benefits that I have being a part of the Mount Sinai Health System is that I have a team that's dedicated to this prior authorization. But even with that, I find that we have issues with getting patients medications, especially if they have insurances that are not considered, the Cadillac version of insurance, and it harms patients. And I think that advocacy is a way that we can really make a difference in terms of this. Speaking to our representatives, like I do with the ACG every year, the American College of Gastro, can really help us push the needle on that. And prior authorization is one of the things that's a top priority.
Right. And so, Dr. Falaye, there's this evil term called step therapy or fail first.
Yes.
What does that term mean to you and to your patients? And what are your insider tips or tricks away around some of the barriers that might pose to our patients in terms of them getting the care they need?
Yeah, step therapy is this really unfortunate uh, issue we face where an insurance company insists that you use other therapies that are unfortunately often less effective and often have way more side effects than something that you know would be more effective initially. This is problematic because when you use the less effective therapy first, you may have all the side effects and very little benefit before you're allowed to use a stronger therapy. And that is given extra time for the disease to take hold and makes it harder to get inflammation under control and get people better. This is especially difficult for pediatric patients because there are very few medicines that have a pediatric approval. And therefore, a lot of the therapies that you think of very commonly may not have a pediatric indication, and we have to go out of indication to get those medicines for our patients. But our patients are also suffering, and I'm not going to just let a kid suffer because there's not an indication when that is the right drug for them.
Yep. So it sounds like you're saying that the FDA, our organization that regulates medication, doesn't yet have all the evidence to prove that these meds work in the pediatric population to give them that indication that it's okay to use the meds in these fields, but that providers know that the meds work and have for decades used this exact medications for these patients. And so that sounds like a big barrier. How can the patient begin to address these factors? What can they do, whether it's with their insurer, with their provider, with an office, or the pharmacy, the pharmaceutical companies themselves? What can empower the patient to overcome what seems like a pretty high burden or obstacle to overcome?
Yeah, that's a great question. I think with your provider, keeping your provider informed about if a medicine is not working is essential. Because when I'm writing a prior authorization letter or request for that next therapy, I have to put in there, we tried this medicine and it did not work because of these reasons. That will just make that letter much stronger. In terms of with the pharmaceutical companies, petition them. You can absolutely contact them and say, please make this medicine available for my child, or for, it's too expensive, and they often will have programs that can assist if you have certain kinds of insurance, or that will encourage them to submit the data to the FDA or to even undertake the trials so they can submit the data to the FDA to get it approved for children. In terms of advocacy further, I absolutely agree with Dr. Lewis. Letting your representative know that your insurance company is denying you appropriate therapy and best therapy for you is a great way. And we've seen some success nationally with the Crohn's and Colitis Foundation and other organizations like ACG that have pushed on representatives to say, we need better therapy sooner so people can get back to life, get back to work, not feel terrible all the time. So all these different things can help with getting authorization and getting your medicine faster for sure.
And Dr. Lewis, again, you work at the Mount Sinai Hospital Systems, getting patients who have a varied range of economic backgrounds and getting the care that they need. And so, what are some of the tips and tricks you use for your patients to empower them to get the care that they need in these settings?
One of the things I think is really important is that when we're thinking about medications is that the patient be an active participant in that decision making. It's not about just me deciding that a medication is right for a patient, but a joint decision. So if a patient is working nights, is asleep during the day, because that's the job that's available for them. I can't put them on an infusion where the infusion center is open from 9 to 5, right? So we have to be flexible in our approaches, and we have to take the patient's lifestyle into consideration when we make a final decision about medications. The other thing too that I think is really important, especially when we're talking about our patients of color, is that a lot of these patients get delays in care because they're not believed, right? Um, we're seeing now that there's this emergence of inflammatory bowel disease amongst patients who do not look like what we were taught in medical school those patients should look like, right? And so patients come in and they try to access care and they're told, well, your symptoms aren't as bad as they should be. For example, I had a patient, a 39-year-old gentleman who for 10 years was told he had irritable bowel syndrome, never received a colonoscopy. And by the time he saw me and I scoped him within a couple of weeks, we found that he had not only ulcerative colitis that hadn't been diagnosed, but cancer at the site of the ulcerative colitis. And so this was a Black patient. People were not thinking about inflammatory bowel disease. And I think it's so important that patients be empowered to actually be a part of the decision making. If they feel like they're not getting answers, looking for providers who will give them those answers and will investigate their symptoms, I think is something critical.
That's excellent. It reminds me of a statistic that we know that uh, since the 1970s, the rate of IBD increase in Caucasian populations has increased by 39%. But over that same period of time, it's increased by 134% in non-white individuals. And so there's quite an increased awareness, or there should be, that IBD, Crohn's disease, ulcerative colitis is a disorder that can affect Black patients. We'll say it again. Crohn's disease and ulcerative colitis can affect Black patients and other minority patients. And so that unlike what we were taught in med school many decades ago, that is the case. And we know that along with that comes other issues of what we call social determinants of health. And so do either of you want to talk about what a social determinant of health is? What could that mean?
Have you take a stab at it? We talk about this in relation to things that are not specific about healthcare, but that can affect your ability to get healthcare, your ability to, your likelihood to get a disease, or to be able to improve from that disease. So this can be where you live. This can be the density or number of healthcare facilities close to you. How do you get to those facilities? And it can be other things. You've heard about insurance already. That definitely is a huge factor. And that can also, depending on the type and your ability to access care, involve social determinants of health.
And so for either of you, when you have a patient who you know, let's say there might be food insecurity, or there might be stressors in terms of financial insecurity or even housing insecurity, what could a provider do to help a patient? And the corollary to that, what can the patient do also in terms of advocating for themselves in those situations as well?
I'll take that question. I think the idea of having open communication with your physician is something that's important. So I had a patient, actually, a young man, who had no problem telling me that he wasn't able to access a living situation that was safe. He was intermittently homeless, but he felt comfortable enough with me to share that information. And because of that, we were able to get social work involved. We were able to write letters to the shelter that he was staying at to ensure that he had easy access to a bathroom, and that in that time he was supported so that he could transition to another living situation quickly. And so I think us being direct with patients, telling them that we want to know what's going on with you, asking questions about how are you doing, right? And what's going on in their life outside of just the disease, because we're dealing with people, not diseases, right? And so keeping that open line of communication where patients are comfortable sharing that kind of information is really critical.
That's great. When we look at statistics from 2024, from a recent meta-analysis, it shows that when it comes to IBD patients, about 1 in 8 have absenteeism, frequent absenteeism, but about 1 in 3 have presenteeism. So they're there at the job, but just not as productive as they feel they should be. And it's not just with work, even when it comes to non-work activity,
Mm.
almost 50% report non-work activity impairment. And so, how do you explain this to the loved ones, to the friends, to the employers, to the professors of our IBD patients? They might be online, they clicked on the link, they're listening right now. Dr. Falaye, be the advocate for the patient in this moment. What should they know about what IBD patients are going through?
Yes, absolutely. So the first thing when there's a new diagnosis that I tell the patient, and in my case, their family or caregivers, is that IBD affects the whole family, not just the patient. The stress, the worry, the losing sleep, the, planning, where can you go and where can you use the bathroom, all of those things affect everybody and impact, as you've stated, where you may go, how well you can participate in those activities, what jobs you can take. We know pediatric patients with inflammatory bowel disease achieve less. They have delayed academic achievement and other things, and sometimes feel the need to drop out of their academic goals because of the disease. And this is terrible. And so we want people to feel empowered to mention when they're having sleep problems, when they're having depression and anxiety, which is known to be 3 times as common in patients with inflammatory bowel disease as patients without, and make sure they get those things treated. You're going to have more flares if you have these issues. And so I ask them about it. I screen every year for anxiety and depression in my IBD patients to try and catch this. This may also happen in their caregivers who are sad about things that the patient may not be able to participate in. And so it's really important that when someone asks, how are you doing in a medical office? It's not a social question. It is a question about your well-being, and whatever is bothering you at that time should be brought to the forefront. There are apps that can help you find where the bathroom is. There's a campaign to help people get to the front of the line at a bathroom. We write letters, as has been stated by Dr. Lewis, to help you with work situations or school situations. I write those letters for college to make sure you can have a car so you can get to the doctor's office, or so you can have a room in your dorm that's not going to be 3 floors up from the bathroom. All that there are things that we can do to address the things that go along with having inflammatory bowel disease. And we want to help with those things, but we need to know about them to be able to do that.
This brings us perfectly into the issue of behavioral health and some of the barriers that poses to our patients. Another stat is that 84% of adult patients with IBD report disease-related stigma that makes them feel unreliable, difficult, or antisocial. And so, we've talked about a bit in a Debbie Downer way, all the negative aspects in some sense of IBD. But what kind of hope, what kind of empowerment, Dr. Lewis, can you offer your patients who have to deal with the stigma? What tools can we use, and what practices do you use day to day to encourage your patients about the future of IBD?
Right, right. Thank you for the question. I think the biggest thing that we can arm patients with is knowledge, right? First, the knowledge that they are not alone and that they're not struggling in this alone, and that there are millions of patients who have the same condition. And so often, when I have patients who have family members who just don't get it and don't understand what they're going through, I tell them to bring them. Come to the visit. Let's discuss this. Let's talk about what's happening so that they can get a better sense of why they're feeling the way they do. I'll show them the pictures of the colonoscopy. The family will be like, wow, that's going on inside of them, right? Because so much about this disease is invisible, right? Because it's happening on the inside. We have some patients who will have extraintestinal manifestations and rashes and other things, but most of this is invisible. And so I think it comes back to being armed with the knowledge of how do I explain this to my family? And also, groups like the Crohn's and Colitis Foundation that have support groups, I think also help to give patients language, help them figure out how to talk about this with their loved ones, and also better understand the disease themselves. And so that when you have a actualized patient who knows what's going on and can explain it, I feel like a lot of these things start to fall away.
Great, great. And then Dr. Falaye, what about you? What are some additional things you do to help lift the optimism in your patients regarding what it means to have IBD?
Yeah, so I like to tell patients that my goal is for them to have as normal a life as possible despite having this disease. And that means working on medications, working on some of those other issues we've brought up, working on their nutrition, working on all the aspects that it takes to be a healthy person. And then the next part of that is they need hope. And so I talk about how that I'm sorry they have this disease, but having this disease today as compared to 20 years ago or 50 years ago, or I talk about people who had it hundreds of years ago that we found in historical records, we have therapies that can help them get better and have fewer side effects than therapies in the past. I don't expect them to spend weeks in the hospital, incapacitated. And that used to be the norm. And so I talk about all the advances and the fact that we pay very close attention to this, that I'm going to monitor them and look for signs of disease activity and act on that to make sure that their life is better than it would have been if they had been diagnosed with this or developed this disease in the past. And so, as much as this is a horrible disease to have, there is a lot of hope that people can have fairly normal lives if they stay on their medicine and follow through with their appointments, and work with their provider to have the best life possible. And that is a possible thing.
Excellent, excellent. And so this brings us to the last segment where we're going to talk about some of the barriers our patients have when they consider fertility, they consider family planning. A lot of patients we know have volunteer infertility, where voluntarily they've decided not to have kids because they're concerned that if they have a child, that they're very likely to have IBD. And so the stats actually show that with one parent with inflammatory bowel disease, the risk of the child having the disease is about 10% or so. And with two parents, the risk is just about 33% or so. And so, interestingly enough, the odds are that a given child would not have IBD, although it is increased from general population risk, which is about 1% risk in general. And so, what do you talk about with your patients, Dr. Lewis? Again, we know Crohn's colitis is a young person's disease. When they think about these issues of family planning, when they think about these issues of fertility, what kind of hope or guidance do you give them in terms of activity of disease and planning for pregnancy?
I think the first thing to do is to dispel myths, right? There are a lot of myths that patients hear about inflammatory bowel disease and how it affects fertility. And for most patients who haven't had any surgery in the abdomen, their risk of infertility is about that of the general population. And so a lot of patients are reassured by that fact. And also, depending on what type of inflammatory bowel disease, the genetic component can vary. So there's much less of a genetic component for patients with ulcerative colitis compared to those who have Crohn's disease. And so, you know, I think it's really critical that we arm patients with information, as we said before, and also link them in with the physicians who can make sure that they are investigated if they do have issues with fertility. So I often will not hesitate if a patient has been trying to get pregnant for 6 months or so to refer them to a infertility specialist who has knowledge of patients with Crohn's and colitis, because that can make the difference between them having their reaching their goals in terms of having children versus not. And so I think that that's a critical part of the picture.
I think that's excellent. We're all, as providers, familiar with the work of Dr. Uma Mahadevian in the piano trial, where she's tracked patients with inflammatory bowel disease on medications and see how they've done over time. And recent data has come out showing that yes, there can be a plan for IBD patients to have children safer than otherwise. Getting your patient in remission 3 to 6 months before trying to get pregnant, shooting for those biomarkers like your blood levels, CRP levels, or your stool fecal calprotectin levels to be normalized, and just making sure you have what we call endoscopic remission. That is looking with the colonoscopy, it looks like everything's great. If we put the fire out of the kitchen, it's less likely that there's going to be smoke and inflammation in the apartment later on. And so it's very important in our patients that we deal with that 6 feet of inflammation that can be going on in the colon so that the rest of the body is healthy and well and amenable to baby being brought to term. So, Dr. Falaye, on your end of things, I know that your patients hopefully are not too frequently having children, given that you're a pediatrician, but you do see it on the side of breastfeeding, and that's one of the other recommendations that came out, where the piano group said that, in particular, patients who are on medications, advanced therapies, should stay on their therapies, and that was important. As a person who kind of sees that transition between child going to an adult, and then also just has the experience of babies up to patients who have IBD. What's your experience? What's your words of wisdom to those families?
Yeah, I think it's been really encouraging that people who are on medicine do well and seem to have better lives and able to raise their children well. I do see patients who come because their parent has inflammatory bowel disease also, and they're worried about, does the kid have it? Will the kid get it? And I reassure them that first, they know what to look for, and they're not going to hesitate to get that checked out if they are worried about symptoms. And then I say, hey, if you're worried about your kid is having symptoms, and it seems more than like a general GI bug, let's just send a fecal calprotectin. If it's elevated, we're going to look quickly. If it's not elevated, there's no active inflammation at that time, and we just keep an eye on other factors such as growth, which is a big one in children. Kids with inflammatory bowel disease may present with short stature or with declining growth, and we would check again in those situations. For the breastfeeding moms, we tell them for the most part they can breastfeed. And we're really glad as long as there's not a separate medical issue or infection that would prevent that. And the kids do great. Like it's really incredible. The human body is truly incredible. For people who are heading off to the adult era, I try not to use things like methotrexate, which is the one medicine that you absolutely should not take if you are planning to get pregnant. And so for my teenage girls, once you're starting to have periods, I kind of stopped giving you that medicine just because most of the pregnancies in my era are not planned. And so we switch off that medicine and use something else. But it can be a good adjunct medicine or solo medicine for a few people. And I would use it in other situations. And I do even have kids who have told me they don't plan to have their own children, as you stated, because they're worried about passing it on or passing something else on. And I tell them that as a pediatrician, I definitely am not going to be going through that decision with them, but I want them as healthy as possible just so they can have a great life. And if they choose to change their mind in the future, then their body is ready.
Excellent, excellent. All right, so we've talked about access and advocacy. We've talked about the barriers of behavioral health, and we've talked about the barriers that patients can consider when it comes to family planning and fertility. And so now I want us to just end the segment by addressing any of our allies in governance, our allies in medical insurance, our allies in the pharmaceutical industries. If you could give them a 1 to 2 wish list for your patient or ways that they can step in and help and think broadly, what would you say to our leaders, to the insurers, and to the pharmaceutical allies out there? I'll start with you, Dr. Falaye.
Thanks for the question. To the pharmaceutical allies, I would ask that your trials represent the whole population, not just a narrow segment, because people do react differently to medicines. And we want to know that before we're giving that medicine to them in clinic. We want to do the best for the patient. And so please include them at the beginning so that we know about those things. To our allies in governance, please make care available to everybody, not just people who have the best of the best insurance. Everyone should be able to get better because everyone lives here and participates in our economy and participates in our social structure. And we just want people to feel better. That's why we do what we do. To the people who run HR departments, please don't just pick the cheapest insurance. Make sure that insurance will cover medicine for patients who have diseases like inflammatory bowel disease. And then to schools and people who work in areas over, for example, like your workers or other places like that. There are people who are not able to sit at a desk for 8 hours a day. Or who are not able to stay in one place for 8 hours a day. They may have to have access to the bathroom. They may have to stop. They may have to modulate their meal plan. They're not trying to be difficult. They're not trying to not work. This is something their body has done that is being worked on, but they may still need a different schedule than others. Please grant it to them. You will have grateful workers who will work harder for you than if you don't, when you'll have things like presenteeism and absenteeism.
Excellent, excellent. So she said it all, but Dr. Lewis, any
I'll just,
additional? Yeah.
yeah, no, I completely agree. And I think what I'll add to that is to our friends in the insurance industry, don't be a barrier to these patients. Allow them to live their life to the fullest. And do not stress out the physicians and other folks who are trying to deliver care. We all want to be able to live life to the fullest, and we all are patients at one point in our life. And so I'd ask that you honor that and make it a simpler process for patients to access their care.
That was excellent. I'd like to once again thank Dr. Falaye and Dr. Lewis for a very exciting segment this year's Insider Tract, where we got to talk about the barriers to IBD care. And thank you for your attention. Please tune in to additional ABGH programming at our website, blackingastro.org. Thank you and goodbye.